Welcome everyone. It's the top of the hour. We'll get started. I'm Dia Wagasback in Houston. And today we are continuing our clinical trials conference series, which is a joint venture between GlomCon and NephCure. Today's talk is titled Pathology in Clinical Trials, and we're excited to welcome Dr. Laura Barisoni. As a reminder, this talk, NephCure mission is to accelerate research for effective treatments of rare forms of nephrotic syndrome and provide education and support to those to improve lives of those affected by protein spilling kidney disease. And one thing I'd like to remind everyone of is their Kidney Health Gateway, which is an excellent resource for physicians, patients, their family members to find trials that may be happening that are near you or that you may qualify for and be interested in. So Dr. Laura Barisoni is a professor of pathology and medicine at Duke University, where she serves as the director of the Renal Pathology Service and co-director of the Division of AI and Computational Pathology. Over the last 20 years, she's contributed to science with numerous translational research projects on human kidney biopsies and animal models of kidney diseases. She pioneered the application of digital pathology to nephrology clinical research and trials and established several digital pathology repositories for kidney biopsies in the setting on international nephrology consortia, such as the Nephrotic Syndrome Study Network, Cure Glomerulonephropathies, the International Digital Nephropathology Network, and the Kidney Precision Medicine Project. Over the last decade, she leveraged digital pathology platforms to develop new scoring systems for kidney biopsies to test drug efficacy and for integration of morphologic data with clinical and molecular profiles. In collaboration with computer scientists, she is applying image analysis tools to extract visual and subvisual features from the digital kidney biopsies to uncover the association of morphologic features with molecular mechanisms, enhance our ability to diagnosticate, prognostic, and predict outcomes and identify new therapeutic targets. Her expertise in renal pathology, digital pathology, and integrated translational research has been instrumental to help the design and implement novel methodologies for enrollment and analysis in clinical trials. And we're very excited to have her here today. We had a series last year where we did a lot of computational pathology and AI, and now it's exciting to hear more about how to translate that into clinical trials. So with that, I will stop sharing and turn it over to you.
So thank you. Thank you for the introduction, and thank you for inviting me to, I need to share my screen. For inviting me to give this talk on pathology clinical trial. I believe you see my screen now.
Yes.
Okay. So this is my disclosure. And I would like to talk about pathology in drug development. And the role of pathologists has been recognized a long time ago for clinical and preclinical phases of clinical trials. For the preclinical phases, even in the early 90s, it was stated that there was needed a morphologic evaluation using multiple stain was needed. In the clinical phases, pathologists participate to eligibility, enrollment, but also to measure efficacy in some of the studies, and their role and contribution can be very relevant. Pathology should also have an active role in recruitment of patients in clinical trials, as they are the individual that first make a diagnosis in a way. So, but how can pathologists contribute? Well, first of all, they have the domain expertise on the kidney tissue, but it's very important that they have a full understanding of the goals of the trials and the effect of the drug at the molecular and the tissue level, so they can contribute to the study design and guide the selection and assessment and inclusion exclusion criteria for eligibility and enrollment, guide the selection of primary surrogate and exploratory tissue biomarkers, contribute to the development and implementation of pathology analysis and scoring approaches, and also guide reproducibility and adjudication processes. How do they participate in recruitment, though? Well, it's very important that pathologists understand the current landscape of the clinical trials. What are the enrollment criteria of the clinical trials and the mechanism of the drug? Information is very important. Information brings knowledge, and knowledge foster distribution of more information. So it's important that there is an easy access to clinical trial websites, and that conversation are made with the nephrologist every time we make a diagnosis of FSGS, IgA, or any other disease where there is a clinical trial. And but one of the things that we also need to keep in mind that recruitment will be increased if we somewhat standardize our reporting a little better and enhance our reporting so that we can include information that are useful not only for patient care at the moment with conventional therapy, but also for potential enrollment in clinical trials. How do pathologists participate to eligibility and enrollment? Well, pathologists can be sort of hired to review pathology report. It's generally used by the sponsor to confirm the diagnosis prior to enrollment. It's generally a low-cost step for the sponsor, requires a simple data collection and entry step. Local pathologists can be used for this step. The problem with that is if I'm a local pathologist and I want to enroll my patient, I review my diagnosis, I tend to agree with myself. So there is no quality control step on the diagnosis or other histology parameters reported that may be critical to the process. The use of central pathologists allows a more quality control on the original diagnosis. However, when we review reports, we still have to rely on the local interpretation. And the local interpretation can be variable. We have expert pathologists, less expert pathologists. We don't really have a standardization of reporting. Everybody uses his own language, even though we should standardize the reporting. But that's the human nature. And the quality of pathology reports is variable for interpretation. Sometimes interpretation can be difficult. And also pathology reporting is based on current clinical needs and not necessarily on eligibility criteria. And so that may be problematic. I'll go back to this point. So it's always better to review the pathology material to confirm the diagnosis, but also to collect other histologic parameter or to score the tissue in a way that can be more useful for the clinical trial. Obviously, it is more costly. It requires more pathologist time, which need to be compensated. Also, a more complex infrastructure and logistic module. Again, the review of the pathology materials can be done by the local pathologist, having the same problem. There is no QC process. Can be done using the historical round-robin glass slides review, where the pathology material is moved from one pathologist to another, mailing, which is what we used to do. But more recently, the use of digital pathology has been implemented, and this has solved a lot of problems. Glass slides are scanned into all slide images that can be viewed on the computer. But the scanning of the glass slides and the storing into a server together with electron microscopy images, for example, allows for the anywhere, anytime access of the images. And so this permanent library can be used for review by multiple pathologists for adjudication process to test reproducibility without having to move the glass slides from one place to another. No matter how we do this, though, pathology review still carries some reproducibility issues. And so we need adjudication protocols, and we need to participate as pathologists to this process. One of the major concerns, though, is the alignment of pathology data with trial needs. And this is a very important topic. And we have to ask several questions. So are current classification systems capturing data that can be used for enrollment and eligibility? Are current classification systems aligned with disease patient's phenotype? And do current classification systems provide information to guide the best patient trial match? Historically, pathologists have used the microscope, light microscopy, immunofluorescence, and electron microscopy to provide interpretive diagnosis. They use a holistic approach. This is what we currently use. So we look at the biopsy and we say, this is FSGS, this is IgA, etc. But to do that, to make that call, we use few glomerular preselected parameters. And they're really a handful of parameters. They do not reflect the complexity of the morphologic changes at the tissue level. That is not only the presence and absence of a segmental sclerosis, but there are a lot of other glomerular parameters that may be relevant, as well as tuberointerstitial parameters. Also, current classification systems do not take in consideration underlying mechanism and molecular profile for each patient. So when we look at the current landscape of clinical trials and we look at our current classification system, there is a sort of mismatch between conventional pathology and the therapeutic targets. Conventional pathology says the disease target is FSGS, but FSGS or IgA or any other disease represent a group of very heterogeneous diseases. So this holistic approach may be limiting the way we approach clinical trials. So some steps to innovation have been made and more steps are needed. We need to really start thinking about a modern approach to healthcare, whether it's for patients' care with conventional therapy or clinical trials. We know that the individual clinical phenotype is the result of genetic variation, epigenetic modulation, transcriptional regulation, protein function, metabolite level, and disruption of the organization at the tissue or cell level. So really to define each individual clinical phenotype, we need to apply a multi-level analysis that can give us a more precise diagnosis, biologically and clinically relevant disease stratification, and that allows for a data-driven selection of patient-specific treatments. We have to start, I'm a pathologist, so I will start with pathology, changing the paradigms in pathology. Currently, as I said, we use the one-size-fits-all approach. Pathologists create disease categories based on few pre-selected features, and then they test them against outcome. But we really need to start thinking about how to apply integrated pathology. Integrated pathology takes into account all structural changes and individual variability, and apply unsupervised learning and multi-axial data sets to define categories of patients with similar biological trajectory to better predict outcome, but also to identify targets for therapeutic intervention. With this in mind, new science has developed named computational pathology. And computational pathology is an approach to clinical research, trials, and patients' care that uses multiple sources of raw data, extract biologically and clinically relevant information from this high-dimensional data, using mathematical models, and generate clinical actionable knowledge, for example, diagnostic inference, prognostications, prediction, and data for enrollment in clinical trial. Uses this knowledge for discovery to inform clinicians to optimize clinical decision-making while maximizing patient safety, to design a decision support system that will allow for continuous quality improvement beyond the current best practices, and then only are faster but also less burdensome to the stakeholders in the healthcare environment. And obviously to identify biomarkers and targets for therapeutic intervention. So the use of digital pathology fits well this idea, and also opens opportunity for enhanced pathology analysis. As I said, the scanning of glass slides into all slide images allows for the creation of permanent libraries that can be viewed by multiple investigators at the same time, but also allows for the application of multiple modalities for pathology analysis, from human visual assessment using conventional methodologies or novel methodologies, to computer vision for the detection, segmentation, quantification, labeling, classification, prognostication, and prediction of kidney diseases, but also for the identification of novel parameter or signatures that we could not identify using the human visual assessment. So what are the novel approaches that have been proposed for patient profiling, and also to enhance our ability to identify patients to enroll in clinical trials? Neptune Consortium is a consortium that was created over a decade ago, and is based on the model on a robust protocol for tissue procurement and data collection. So blood, urine, biopsy tissue, clinical information, demographic data are all collected. Patients are phenotyped molecularly, morphologically, to identify molecular predictor of clinical outcome and response to therapy. And of course, is based on a large digital pathology repository, so all the kidney biopsies are collected. The idea is to identify biological mechanism of renal disease that can guide the therapy. So this collection of data allows for a comprehensive profile of each individual patient, to predict responses that is used to predict response to standard of care, to predict clinical trials, for example, identify biomarkers for targeted therapy selection, or to monitor the therapy selection. But also it's used to identify and repurpose clinical trials, or match drug with pathways in individual patient, or identify targets for the novel drug development. How does pathology fit in this process? So the pathology working group has generated a protocol that is agnostic for tissue analysis, that is agnostic to conventional diagnosis. And has identified a variety of features that name descriptors that are observational data that represent the discrete element of the structural changes that can be seen in the kidney. And these features, over 80 features, include glomerular parameter, tubulointerstitial parameters, ultrastructural parameters. The glomeruli are enumerated on the screen across all levels. And an electronic scoring sheet is used to score these biopsies, so that the pathologist, again, agnostic to diagnosis, review each individual glomerulus and select the parameters that observed throughout the entire biopsy, so that it obtains at the end a complete glomerular profile. The same is done for the ultrastructural analysis and the tubulointerstitial analysis. How can we use this data? Well, we can use this data to let the computer basically group together patients based on morphologic similarities. And we can choose to do that using all the parameters together, so using the entire landscape of the biopsy, or for example, the glomerular parameters alone. We can use individual parameters to test their association with outcome, etc. This is an example where we use the glomerular parameters only. And we did a patient cluster analysis on 221 FSGS and minimal change disease patient using the glomerular descriptors. And we obtained 3 clusters, X, Y, and Z, where cluster X is the one with the worst prognosis and remission to proteinuria. Each of these clusters contains a variable amount of FSGS and minimal change disease. When we look at this heat map, here I represented all the parameters, and the darker is the bar, the more frequent descriptor is represented in each of the cluster. The numbers here indicate those parameters that drive the clusters. And if you look at these parameters, the majority of them, those are parameters that are not included in current classification system. We don't classify FSGS and minimal change disease based on the presence of deflation or obsolescence or periglomerular fibrosis or epithelial cell hypertrophy. But yet these parameters seem to be relevant for patient clustering. And when we compare the patient cluster to conventional classification system, there was only partial overlap. Also, the cluster, had differentially expressed genes, and several of them. And when we look at the top canonical pathways, obviously there were different canonical pathways that were activated in each of these clusters. But when we look at the top upstream regulators of these canonical pathways, they seem to be the same in all 3 clusters. Interesting, they were activated though in cluster X, the cluster with the worst prognosis, and inhibited in cluster Y, the cluster with the best response to conventional therapy, indicating that the morphologic-based patient clusters are not only clinically, but also biologically relevant. The same we did with we're using the ultrastructural analysis alone. And these FSGS and minimal change disease patients, that FSGS and minimal change disease are also known as podocytopathies. And one of the things that people associate with podocytopathies is podocyte damage, and most importantly, the food process effacement. It's the first question that any clinician asks pathologists when they report the diagnosis. There is FSGS, well, how much food process effacement? So we use these, we collected data on the status of podocytes that include effacement, loss of primary processes, condensation of cytoskeleton, detachment, microvillus transformation, but also on the status of the glomerular basement membrane thickening, thinning, other abnormalities, and the status of endothelial cells. And when we did the patient cluster analysis using this data, we obtained 6 clusters. Cluster 1 is composed by patients that have very little of everything, but very little. Cluster 2, 4, and 5 are patients that have the majority of abnormalities in the glomerular basement membrane associated in different way with other features. So the association of basement membrane damage with other features determine the cluster. Cluster 3 has features that most likely resemble our classic minimal change disease, mostly podocyte features. But cluster 6 had features that were mostly associated with abnormal status of the endothelial cells. And cluster 6 is the cluster with the worst prognosis in terms of eGFR decline and remission of proteinuria. And we also noticed that endothelial cell descriptors individually associated with poor clinical outcome. and more frequent, and they were more frequently represented in clusters with poor clinical outcome, which was a surprise as we think about podocytopathy as a podocyte issue. And indeed, there is food process effacement, but they may not be relevant to the ultimate outcome, nor to the underlying biology of these diseases. In fact, over 1,000 genes were significantly differentially expressed between minimal chain disease and FSGS with evidence of endothelial cell damage versus those without. And when the differentially expressed genes were then subjected to pathway enrichment analysis, 4 pathways were found to be significantly enriched. And those are key to endothelial cell morphology, growth, and angiogenesis. So this data show that if we perform a more agnostic data collection and collect a variety of parameters across all component of the renal biopsy, we're able to identify a group of patients that have not only morphologic similarities, but that morphologic similarities can also represent a surrogate biomarker of molecular signatures, and they can be, and these clusters can be clinically and biologically relevant. So how do we going back to the clinical trial, how this can be used in clinical trials? So one of the proposal of NetGen is to collect this data, curate the data, analyze this data, and integrate the data using machine learning tools to identify patient-specific integrated profiles and generate some sort of trial scorecard. So identify which is the profile that could best match the activity of one compound versus another. If we enroll all FSGS patients in one clinical trial, we know that some will respond, some will not, because we do not necessarily match the mechanism of the drug with that patient phenotype. We just use a very broad group of patients. So the idea is to narrow down the patients that can be enrolled in a trial versus another. Morphologic analysis done using visual assessment, though, carries some reproducibility issues. Obviously, is subjective and can provide a lot of information, but more information are encoded in the tissue that cannot really be retrieved by visual assessment. So the vision for the future is to use or start applying computer vision. Computer vision can be used for the detection and quantification of histologic primitives, and a variety of models have been published, mostly for the detection and quantification of glomeruli. The most popular approach is to use deep learning, which is based on the manual or semi-manual annotation of the object of interest. In this case, we have here the glomeruli, the inflammatory cells here, or the mesangial areas, in this case of diabetic nephropathy. Once the training data set is annotated, then can be used to train the deep learning model. So the deep learning model can be used for the detection and segmentation of the boundaries of the object of interest across all stains. In this case, we have the glomeruli, the glomerular unit, the glomerular tuft, the proximal tubule, the distal tubule, proximal tubule, distal tubule. We have arteries here, and even peritubular capillaries. We can measure interstitial fibrosis, we can measure inflammation, and a variety of other parameters, which can be used for correlation of clinical outcome. For example, here is represented the automatic quantification of global sclerosis. And if you remember, global sclerosis was one of the parameters driving the cluster, the patient clusters. Once it's adjusted for age, we can identify patients that have increased or decreased survival probability. Inflammation can be quantified, whereas usually when we measure inflammation, we are on the mild, moderate, severe, or the most we give the percentage, but here we can count individual cells, and that can be clinically relevant and helpful. Vijay Kolkalama has shown that when he trained the computer to detect interstitial fibrosis, the computer outperformed the pathologist in predicting creatinine, proteinuria, eGFR, and survival. So the computer can be used to make more reproducible what we can do visually, measure interstitial fibrosis, global sclerosis, segmental sclerosis, etc. But a computer can also be used to provide information we will not be able to provide. Using next generation pathologic extraction. So extraction of features that are not visible, not measurable by us. That could be the shape, the size, the density, the angulation, the orientation of the object. In this example here, we develop a deep learning model. There are over 6,000 glomeruli represented in this heat map. The deep learning model detected non-sclerotic and globally sclerotic glomeruli from frozen section of donor biopsies. And then we struck atomic. And we did a cluster analysis of all the glomeruli. Each column represents the cluster. Each row represents the pathomic features. And we have 4 clusters represented here. Interestingly, all the globally sclerotic glomeruli, most of them cluster in cluster 4, which is expected that they cluster together. But they also cluster together with non-globally sclerotic glomeruli, indicating that there are some similarities between the non-globally sclerotic glomeruli and globally sclerotic glomeruli that we obviously cannot detect by naked eye, but they are at some level detected. And they may be very important in predicting outcome, for example, or in predicting what is happening to glomerulus before it actually happens in real life. This is another example where we measure the densities of peritubular capillary that resulted to be relevant for prediction. This is a parameter that we never use in clinical practice nor in clinical trials, but actually can carry some information that we have not explored yet. And again, a cluster analysis, so this is a cluster analysis, a heat map showing the peritubular size parameter for each patient. And we can identify a group of patients with similarities in peritubular capillary size and retrieve information encoded in the kidney that will not be able to retrieve otherwise. I want to move to participation of pathologists in study design to measure efficacy, how pathologists participate to study design and innovation, and how they have contributed with innovative ideas. This is an example of a Fabry's disease clinical trial run by Genzyme 2 decades ago. They treated patients with enzyme replacement therapy, and they took biopsies at baseline and at 6 months. And they asked pathologists to look at these biopsies. And pathologists noticed that GB3 inclusion were present in all sorts of cells, in tubular cells, portal cells, mesangial cells, endothelial cells, etc. But at 6 months, they seem to be a lot less in endothelial cells or peritubular capillaries. whereas they were still there in podocyte, for example. So they created a scoring system where they evaluated the biopsy, and they gave an overall Gestalt score of the biopsy based on the presence of the GB3 inclusion in endothelial cells of peritubular capillary. And if a biopsy had a score of 0-1, they rescored those biopsies with a more granular scoring system that was still semi-quantitative. So the final biopsy score was based on the majority of capillaries with a given score. Now, this was brilliant and worked very well for Genzyme. When this, and it was so accepted, but when this scoring system was applied in another clinical study trial, where by the nature of the trial, the patient enrolled in the trial had a lower level of evidence of disease at the tissue level. This scoring system didn't work. The majority of patients scored 0-1 at baseline and post, because it was this process, this approach was not granular enough to detect differences when there is less disease. So study pathology said that it created a different scoring system, proposed a different scoring system. It was very simple, counted the number of GB3 inclusion in 300 peritubular capillary per biopsy. And then the biopsy score was the average of the inclusion per peritubular capillary. And they did that using light microscopy, which implies that the glass slides have to be mailed from one pathologist to another, and then there are obviously reproducibility issues that need to be addressed with adjudication. So everybody has to fly somewhere and meet around the microscope and try to adjudicate 300 capillaries per biopsy, which is very time consuming. So the pathologists decided to propose a different protocol and use digital pathology. So the glass slides the de-identified glass slides were scanned into all slide images that were collected into a digital pathology repository. And they created a protocol by which the scoring was done by 2 steps. First, the peritubular capillary were digitally annotated. So the annotator pathologist would access the digital pathology repository, open an electronic score sheet linked to the image, and manually, but it takes just a second, draw with a mouse an arrow indicating each of the 300 capillaries that need to be scored. And as it was doing that, the capillaries were automatically enumerated. Then the images were duplicated and given to the 2 scoring pathologists, who at this point were scoring not only the same biopsy, but exactly the same capillaries. And that was done for a total of 54,000 peritubular capillaries. When the scoring for using the Bliss protocol, the Bliss scoring system was compared between the use of digital pathology versus Bliss using light microscopy, there was an expected actually increase of reproducibility. But also, that facilitate the adjudication process. We cannot do a scoring without expecting perfect reproducibility and without having an adjudication process. So if you think about, if we have to adjudicate a biopsy by using the microscope, the adjudicator pathologist has to review the entire biopsy, the all 300 or 1,000 peritubular capillaries depend. And when it adjudicates, doesn't necessarily read the same capillaries, read the same biopsy. So by having the capillaries enumerated, we were able to detect, to pull out only the capillaries where there was a discrepancy, which was just a smaller 10% fraction of the all capillaries, and have the adjudicator adjudicate only those capillaries and not the entire biopsy. If we think about use of digital pathology in clinical trials, it really provides full transparency for regulatory agencies. In the past, everybody had to trust the word of the pathologist. I look at the biopsy, this is my note, this is my scoring, and this is it. But now we can prove and QC the scoring system capillary by capillary. In the case of Fabry disease, maybe other objects in other clinical trials, as each score was linked to each specific capillary. So in conclusion, pathologists are the tissue domain expert. They should position themselves in a way that they can gather information and distribute information, having meaningful conversation with the nephrologist once they have a diagnosis of a disease for which there is one or more clinical trial available. Because of their domain expertise, they should participate in study design, but have first a full understanding of what the trial is about. They should participate to enrollment, to assessment. What is needed today, I think, with better information and communication, we need to revise the reporting to facilitate clinical trial process. We need definitely to revise the current classification system, not only for the clinical trial purpose, but in general. Increase the standardization of reporting and data integration. Thank you.
Thank you very much. We have some questions that have come up, so I'm going to ask you some of those, and then we'll allow for people to unmute and ask as well. So one of the questions is in regards to the clusters that you showed, and if from Dr. Poinmeyer, and if there's any, are they different disorders, do you think, or is it a time spectrum of disease? And can you comment on a little bit on that?
Okay, so let me move back to the cluster. You still see let's go back to the cluster for a sec. Okay, so the question is the distinct disorder. Well, when we call FSGS a minimal change disease, in reality, we are giving an umbrella name. FSGS and minimal change disease as well are a very heterogeneous group of diseases. And just historically, conventionally, we chose to call them FSGS and minimal change disease. But in reality, we know that by the way they present, by the way they behave, and by the ideology behind, at least for the ones we know, behind this name, FSGS is just a pattern of injury. So when we generate these clusters, and I think that the cluster should not, if we ever use this cluster in clinical practice, should not be limited to glomerular descriptor only, but we should have a comprehensive, they should be complete of tubular interstitial and vascular disease. They represent group of patients with morphologic similarities that, looking at this figure, they're probably more similar to each other than when so patient cluster X are more similar to each other than when we call it FSGS NOS, as FSGS NOS goes into cluster X, Y, and Z. But cluster X, Y, and Z have different outcome and biologically are different. So our grouping FSGS into NOS or perihilar is a bit arbitrary because it's based on 5 parameters, present or absent, without any knowledge of the underlying biology of the patient. So my opinion is that these clusters are more representative of a homogeneous disease more than what we conventionally use. Did I answer your question?
Thank you very much. Yes, Dr. Barisoni, wonderful talk. So if I can just So two things. So I think my original question was like, as you showed the details, is that are the differences, for example, you cluster them based on their outcomes. So, am I correct?
So the cluster were generated by the computer using the descriptors.
The descriptors, but then
And
they
then
had three clinical.
Yeah, and then they turn out to be clinically and biologically relevant.
Concerning their outcome.
Mm-hmm.
So could that be that it's the same? It's basically like those with more severe outcome were biopsied at a later stage versus.
Okay.
You know, so the question is that the
yeah.
same disease, a different spectrum of severity, gravity, or time course?
Okay, I understand you. So as per the biopsy protocol, the next-gen biopsy, any patient that has over 500 milligrams of proteinuria, this is the first biopsy. Some patient presented to us with more interstitial fibrosis and tuberous atrophy than others, for example, more global sclerosis than others. But it's not, I need to go up here. Let me see this. It's not the more severe, it's how the features combine, associate together that define a cluster. So for example, cluster X had more podocyte injury measured by light microscopy. Hypertrophy, hyperplasia, does it mean that that is more advanced and more advanced? We don't know that, right? There is, for example, global sclerosis was obviously more present in cluster X. As we expect that, global sclerosis is one of the parameters that really drives outcome. Even if you look at global sclerosis independently as an isolated parameter associated with outcome. But if you look at this, and I think that this is where the novelty is, none of the features of segmental sclerosis that we use to make our diagnosis was actually relevant for cluster membership.
Can I follow up with one brief question unrelated to that? Is the focus on refining the ultimate diagnosis, which you then would use for inclusion criteria and so on? Is the focus on the tissue morphology? Is it leaving out too much of the clinical data?
Okay.
Like would your clusters, for example, change or be more refined if you would include also clinical data?
Yes, so actually we have a manuscript in preparation. That is a great question. We have a manuscript in preparation. So this is under review. Then we have a manuscript in preparation where we use machine learning to include all data. And because you're right, it's not just pathology, it's not just morphology. We need to do an integrated analysis. But this is the first step to move away from our conventional pathology. Is FSGS is bad, its collapsing is bad, its minimal change is good. And so, yes, in this manuscript that we have in preparation, we look at all parameters. And when we have, I didn't show the figure today, but when we look at all clinical, demographic, and morphologic parameters, we do have slightly different list of features that drive the cluster, and is a mix between morphology and clinical, which is expected. But one thing I can tell you, food process effacement is lost. Podocyte damage remains fairly high in the list, as well as glomerular foam cells, as well as periglomerular fibrosis, for example, or global sclerosis. So some that are listed here remains in the list of the top 15 and mixed with other clinical data. But what is striking, that food process effacement never makes it to the list. And so when we have conventional diagnoses that are based on the amount of food process effacement, primary versus secondary, I'm really skeptical for those. And I know they're very widely used, but they have no, I don't think they have biological base. They're a little bit arbitrary.
Thank you.
Thanks. And I think one of the questions, since a comment that came up, was about the timing. And so Dr. Glassick had stated that, as the renal pathologist, you have little or no control over the timing of the acquisition of tissue for analysis over the course of a specific disease. Thus, many trials are forced to use pathological material acquired many months or even years before the patient is entered into a clinical trial. Thus, a bias introduced that cannot be corrected by an integrated examination of the tissue. This suggests that research biopsies conducted at the time of entry to a given retrial will needed going forward, and it complicates everything from, as we know, informed consent, trial enrollment, cost, all of that. And so his question was, are there any suggestions on how we can overcome this obstacle, or are there things in the works to kind of go forward from this?
So this is obviously a very important point. How do we measure the status of the kidney? And Dr. Glassick is right? Often we do a biopsy and 2 years later we want to enroll the patient. The status of the kidney may have changed, so the parameters. And I think it all depends what we want to measure. So if the goal is to use morphologic parameters to measure efficacy, we need to have a biopsy at baseline, and we need to have a biopsy at 6 months or a year, and there's no other way around. If we have a clinical trial that aims to measure eGFR, emission of proteinuria, etc., do we need to have another biopsy? In my opinion, it's always good to know what we start with in general. But obviously that creates problem, right? It's ethical problems and recruitment. Patients don't want to have too many biopsies, etc. So there has to be a balance that is taken into account. As we use machine learning to identify patients' profiles, and I'm talking about a little bit in the long run, we may be able to use this data to predict outcome in a way, to predict what the kidney, what the patient will look like in 2 years from now without having to do the biopsy. If we match morphologic features to molecular profile signatures, and then we use a therapy that targets specifically that pathway, maybe we can get away without having to do another biopsy because we know what we are targeting. But I think that we need to start doing more targeted therapies. It's a much better the patient with a specific treatment than what we are doing now.
Yes, and it looks like from everything from the data from your clusters, if you can identify the morphologic lesions that are at risk, that really could potentially open up the therapeutic targets and options and really kind of expand our armamentarium of what we can treat patients with, I think, with not only prognostic, but as you said, therapeutic. Another question that has come up, and you brought up kind of ethical concerns, was from Dr. Fuentes about children and minimal change and the spectrum of minimal change to FSGS, and children are not often biopsied at the beginning, and then thus they're also may not be included in trials. And is this something that maybe we need more information on and should be thinking about this a little differently in our clinical approach to getting tissue from?
If you ask a pathologist whether you should biopsy a patient, pathology will always say yes, because we like to see. But then if the patient is my son, I would be thinking, well, I'm not sure. But if we are able to identify correlation between morphology features and molecular pathways, and then we can measure the presence, activity of these molecular pathways in patients prior to the biopsy, maybe for a fraction of the patient, we can get away without biopsy, right? I think that not biopsying children with nephrotic syndrome until they don't respond to therapy, I would not touch the kids until we have no other options. That will still be my policy. And again, we may be able to reclassify these kids prior to the biopsy anyway into those where maybe we should treat with this versus that, or maybe this patient would not respond to conventional therapy, so we better take a biopsy and do some other analysis, etc.
Thank you. And then I think from the kind of broader scope, as a pathologist, and we know this from our weekly conferences, almost all of you are excellent teachers, right? And we learn so much from you, whether it's from the biopsy report and the references and the things you add to the patient's care in that regard, to giving us talks and conferences from the clinical side of things. What role can the pathologist play in educating patients, and what role is being done in educating patients on what is being done in the clinical trials? Because you said the hesitancy to biopsy in general, then there are risks, it's a procedure, but then how they could best understand what that is adding to the trial itself, the potential therapeutic potential options down the line.
So it depends on the involvement of the pathologists in the trials. Pathologists are historically removed from patients, and we can educate the patients, in my opinion, that's my opinion, in a large conference, and show what the disease looks like, what the disease could look like in the future, what is known, what is not known, what are the potential approaches, what are the clinical trials. If you have this, you may match this trial better if you have that. While it's an open conversation between pathologists and treating nephrologists is highly encouraged, because this is where the decision are made, the understanding of what is happening, and also looking at the biopsy together. And this is where Zoom meeting or digital pathology becomes very helpful, because you don't have to meet for that. You can have a nephrology, a referring nephrology in California, and we can still do that. I think that on a one-on-one basis, the nephrologist is the one who should talk to the patient, not the pathologist. There are a lot of things that as pathologists, we are not used to do, and probably it's not our place to do, but a broader education on what the disease is, or what we don't know, because there's a lot that we don't know about the glomerular diseases. We're still a little bit in the dark age, I think, and a lot needs to be discovered. And I think the patients need to know that, to manage their own expectations in a way.
Yes, thank you. I think that's a question that's come up from some of our, I know Kevin Fowler joins the conference often, and, you know, how we can best translate to the patient, and exactly what you said about, you know, the nephrologist taking the primary role, but even if within the trial setting and trial design that you are included more so that that information can be put out there, and your input, obviously, because it is so huge to what we're doing and trying to advance. Well, we're almost at the top. We're at the top of the hour again. Is there any other questions? You can raise your hand. All right. Well, thank you, Dr. Barisoni. This was excellent. Appreciate you spending the time with us today, and everyone for interacting. I think there's a lot of exciting things on the horizon that's really going to change, you know, continue to move kidney care, kidney disease forward. So thank you for all your work.
Thank you for having me.
Bye.
Bye-bye.